All right, welcome back to Mettle Labs. Again, this is Clay Gregory coming from Metalworks Behavior Health here in Upper Marlboro, although they used to call this Largo, when I was growing up. So now it's Upper Marlboro. I don't even know how they did that. But um, today I got a special guest. I have one of our team members by the name of Dr. Erin Palmer. Welcome.
Hello, hi.
Shake your hand, man. All right, so Erin, that's what we all call you. First and foremost, I think when most people think of, well, let me start this way. What is it that you do?
Oh, okay. Well, I am a psychiatric nurse practitioner.
Okay.
I pretty much function as a doctor, psychiatrist, diagnose, prescribe, and care for patients' behavioral and mental health.
Okay. All right. And so, what made you want to do that?
Okay, so long story. I started as a family nurse practitioner, worked in primary care. I've always had a love for psychiatry, but in that setting, as a primary care provider in pediatrics at that time, I was constantly faced with the challenge of finding resources and support for my patients. And it also took me a long time to cut the cord from the ER. So I worked in the ER as a nurse, and I worked as a nurse practitioner. So
I
I
can
was
imagine you probably had some crazy stories from working in the ER.
Yes, for sure. But
Okay.
I would refer my patients out. They wouldn't get any help. I would see them in the ER. Then it was like a revolving door. So I just
Wow.
went back to just try to see how I could treat them in office. Honestly, that's really where I started.
Yeah.
And then I realized that I could get another license
Okay.
and do psych full time.
Okay. And so, like, let me just make sure I understand this. So, you worked in an ER, an emergency room. So, like, when you see people, either on the news or you see someone, that's walking in the middle of the street and then they come and the ambulance comes and picks them up, someone who's in crisis, they would come to you first?
Well, in that setting, it wasn't necessarily just a psych unit.
Okay.
We had psych, but it was a full trauma ER. So
Okay.
you see a little bit of everything. But yes, that is where they would end up to be stabilized or admitted or sent home.
Got you.
Yeah.
Some people would be pretty intimidated by working in an environment and working with that population. Like, what inspired you to be able to dive into that?
So I went to the ER initially just to grow in my field. Worked on a cardiac and kidney unit for a while with children who had cardiac surgeries and transplants, and I just wanted to learn more. And then once I got there, I loved it. I loved the constant change, the hustle and bustle,
Yeah.
and just being able to help patients honest
Yeah.
answer, help patients and not be so connected, because sometimes it got a little hard being so connected to the patients on the floor, then you lose them and things like that. So you get to help them, stabilize them, and send them upstairs.
Yeah.
And so that's kind of what sent me to the ER. But I just love just helping,
Yeah.
being a part of the community.
Any stories or any cases, and I know we can't use names, but any cases that really resonate with you that that makes you feel proud of, like, some of the work that you've done?
Mental health wise, when I would be, we're still talking about the ER, correct?
Yeah.
Okay, so mental health wise, when I would be on our psych side, really honestly, the best part was being able to be even just a caring space for the kids who came in there. A lot of the times they were there they did come with the police.
Yeah.
They were there because they tore up the room or whatever happened, or they were running away. In reality, they just really want a hug. They just
Yeah.
want somebody to just address that they have trauma.
Yeah.
We see these kids and even adults. I'm saying kids because at that time I was in a pediatric ER, but we see them and we label them bad and things like that. And then you open their chart and they've been through more in their 8 years of life than I've been through in my entire life. And
Wow.
I'm expecting them to be able to handle situations
Yeah.
as if they're regular. I mean, they are regular, but
Yeah,
somebody who hadn't been through that type of trauma. And it's not fair. So
get that.
just being able to be that and to see what it does. I've had kids come in upset and very angry,
Yeah.
and then you get in there and then they ask you for a hug. And that
That's gotta be
simple
touching.
gesture
Yeah.
can just calm them down. Doesn't
Wow.
erase what they've been through or what they did or how they made it to us.
Yeah.
And I had one little girl one time, if you say something I remember, she would call us in there like every hour and just ask for a hug.
Wow.
Whoever walked in the door. That's all she
Wow.
would say.
Around what age?
She was elementary.
Okay.
Maybe like 5th grade, somewhere around
Yeah.
there.
And so, like, in that case right there, if you have a child and they're coming in and all they want is a hug, you know, what is it what's your takeaway from that? Or what are you sensing is wrong in that situation?
I mean, they're looking for love. A lot of even the patients even some of the patients knew to say, I want to kill myself so they could get there with us.
Wow.
You know, because
That's deep.
they're just
Okay.
looking for someone to care. And then they're not getting that at home, or they're just not understood. Their mental health isn't addressed.
Right.
So they're just labeled as bad or crazy, quote unquote, when they know when they come to the hospital that we maybe understand what they're going through or acknowledge that they have a diagnosis, things like that.
So with your clients and the consumers that you treat, how many of them need some degree of like mothering or big sissing or someone that's going to just put their arm around, more so than just kind of like the clinical treatment part of it, but just need that connectedness?
A lot, but probably more than 50% of them. Because, again, it's not always that they came from a bad home environment or they didn't have the parents in the home or things like that. Sometimes it's just the stigma.
Right.
And then not having anybody around who understands mental health or cares about mental health, you know, because they've been told that suck it up, nothing's wrong with you.
Gotcha.
So then they get into a space where somebody can say, it's okay, you feel this way, tell me about it, let's work on it. And sometimes just that is what they need, because all their whole life they may have been dealing with depression and anxiety, and their household told them it wasn't that big of a deal.
That makes sense. When you think of, especially the Black and brown communities, where they're not, and correct me if I'm wrong, I don't know what the percentage of minority prescribers that there are, and not even just minority prescribers, but prescribers that are from here. Like, where'd you grow up?
I grew up here. I grew up down the street.
Okay, all right.
So yeah, Largo.
Okay, all right. So that's what's up. So naturally, you're from Largo, and you are treating individuals who are living in Largo right now. Like, there's a connectedness there, that and a relatability that you're going to have that others who are not from this community, or not from this community, have, right? So I suspect that there's a lot of suspicion around psychiatry and nurse practitioners and doctors, and part of it has to do with the fact that with a lot of our people and a lot of our children, they've been given these big titles as far as a diagnosis, and been put on drugs, given prescriptions that haven't necessarily made them feel better about themselves, and have had some type of consequence that have held them. There's a sense of like being held back. So there would be some distrust there, right?
Yeah.
But the fact that you're local, you're from here, you're from the community, how does that, how are you able to tie that into making it more relatable to them?
Well, culturally, it is easier to just say, I understand, As a Black woman, as a mom, I would understand why you don't want this label on your Black son. I get it. Yeah. And so being able to kind of relate on that aspect, to let them know that I'm not trying to just label your child, but for instance, usually the common one is ADHD, right? So if I have a child who is 10 who has been struggling, now we have to talk about that, because if we let them go on for the rest of their teenage years unmedicated and struggling, that's going to hold them back. Yeah. So can we just, this is to help aid them, not saying this forever. It may be, it may not be, but I always try to set a goal to come off the medicine. It kind of helps a little bit better.
Yeah.
And then once we get to that goal, we reevaluate.
Wow.
Sometimes even if I think that we're probably not going to come off, I just, give them that, like, okay,
Yeah.
we're going to make this plan. And
Yeah.
then we get to this time frame, we'll talk about it. How do you feel? Do you really feel like you need to come off?
Yeah.
Usually the answer is no.
Gotcha.
And they stay on the medicine.
Gotcha. That's valuable. How much do you think, how often, let me put it this way, how often do you think misdiagnosing occurs out there in the community? So a lot of times I'm sure you see clients and consumers who come in and they already have been diagnosed. How accurate do you think the area is in getting people's diagnosis right?
So, I don't really have a true percentage on that, but where that comes from is the lack of resources for mental health. So a lot of the primary care providers are managing and diagnosing mental health diagnosis because they have to. They don't necessarily want to have to manage or diagnose. They want to be able to refer out. But when you have nowhere to send your patients, you have to take care of them. And that's where a lot of that comes from because and I was in that space. I was a primary care provider before. So a person comes in, we do the PHQ-9, they're scoring severely depressed. Okay, you have depression. But then it could be bipolar. It can be borderline personality. It could be so many other things that as a primary care provider, my mind just didn't go to. So now I'm just treating you for depression or I'm treating you for ADHD when you can have bipolar or other mood disorders that are really the root cause. But as a primary care provider, ADHD, I give you medicine, I let you go.
Right.
So that's where those a lot of those misdiagnoses come from. Just trying to help, because that's what all providers are trying to help. But just not having the background as far as experience in it, because we learn it, but when you're not doing it every day, it's just not the same.
Yeah, I get that. All right, and I have to say that I'm really impressed and I'm really enjoying this conversation to have a young sister who's a nurse practitioner who's born and raised in Largo, treating here in Largo, and knows her stuff, y'all. This is pretty fly right here.
That's right.
So let's again, mental health. When you think of mental health and you think of the diagnosis and the terminology, it's pretty intimidating.
Yeah.
Like some people, the moment that you mention, okay, we do mental health, it's like, well, let me stop. I don't know about all that. I'm good, right? So, but I want to see if we can break down what some of the terms mean. Okay. And we'll start with the most basic one. What is mental health?
Okay. So mental health is the health of, let's say, your mood. It is just your overall well-being, like who you are, who you present as, So that would be how I would explain it in the room with a patient.
Okay. All right. And so what's the difference between a nurse practitioner or a psychiatrist?
Okay.
And like a therapist or like a psychologist?
Okay. So nurse practitioner means that basically I started as a nurse, a registered nurse. I worked as a registered nurse, went back to school, got my master's, and also a postmaster's because I did too. And here in Maryland, we have full practice rights. So we practice pretty much the same as a MD, which will be a psychiatrist.
Wow.
So a psychiatrist went to the medical school route, and a nurse practitioner just did nursing first. But there's no separation in what we can do, what we can prescribe. It's all the same here in Maryland.
Okay,
but that does change state to state.
Okay.
For nurse practitioners,
Yeah.
And then a therapist still can provide the therapy and the different types of therapies, but really the only difference is they can't prescribe and diagnose certain things.
Got you. Okay. So the diagnosis that a therapist can perform and the diagnosis that a nurse practitioner that you guys can perform, are they the same thing or is there any differences?
The books would say yes, there's a difference.
Right.
But, in practice, no.
Okay.
Because honestly, therapists are very educated and they know. And they see and they deal with patients sometimes even on a deeper level than me as a provider, because I don't always have the time.
Okay.
So a lot of times when therapists come to, if I am in communication with a therapist about a diagnosis, they could present something maybe that, I think they talked to me about this in session. What about this diagnosis?
Gotcha.
And I'm open. It's all about collaborating together to come towards a diagnosis.
Yeah. Okay. And how does a person know when they should be looking for a therapist or they should be looking for a nurse practitioner? Like what are some of the cues that either we feel in ourselves or we see and witness in a family member?
So truthfully, get to who you can get to first. Let's start there. But it will really be if you need medication, then you really need to go to a nurse practitioner or a doctor, because you're not going to get the resources that you need through a therapist.
Gotcha.
That would be the biggest thing.
Okay.
But otherwise, if you don't know the diagnosis, you just know that something's wrong, just try to get where you can get to the fastest. And then if you do get to a therapist and then they say, oh, you need more, they can give the resources.
Okay. How would a person know that they were needing these services? Because especially for many of us who come from the Southern Christian belt, or the area, coming up from the South, like, we were raised to say, something's going on, go to church. You need to pray a little deeper. You need to fast. You need more Jesus in your life, more so than like health, right? Health resources. So how does a person know, what are the cues that should trigger?
So the biggest thing is quality of life. I always just bring it to that. How is your everyday? If you are depressed, anxious, or if you're sad or worried, which is another, it's a symptom of depression, anxiety, right? And you won't leave the home. You are in trouble at work because of your attitude at work. You're changing your behaviors with your friends. Things are changing in your life. That is a big cue that you need some type of intervention. And praying and going to church is a part of it. But if I told someone that they had asthma and I said, go pray about it, it is not enough.
Right.
And as another thing that I like to do is just related to medical diagnosis, and mental health is still a medical diagnosis, but things that people can relate to a little bit better. Yeah. So if I tell you you have hypertension and I give you this medication for your hypertension, you're going to take it to bring your blood pressure down, right? So if I tell you you have depression and I give you this medicine for depression, then you should take it so it can bring some of those symptoms down.
Gotcha. Yeah, that brings up. I mean, that's deep right there. There's a saying, you can't see the forest from the trees, right? So if you were standing in a wilderness, you just see a bunch of big trees around you, but there's no context to say, okay, I'm standing in a forest, and outside of this forest there might be an ocean on one side and a city on the other side. You would have to almost be outside of the forest, standing on a ledge, to realize that I'm in the forest. I bring that up because there are plenty of people in our communities who were raised in houses where there was active depression.
Oh yeah.
And so it just was the fact that mom just never was in a good mood, and mom never smiled, and she never left the house. We were raised in an environment, so this seems like it's normal. How can I tell what's normal? Like, because that life is hard, right? And there are parts that are difficult to deal with. But how can a person determine whether or not this is just natural life and life is just tough, versus like, okay, something is really going on with me?
Yeah. I mean, again, and that's still related to quality of life. And if you have that question, then that's when you know that you need to go ask somebody else.
Got you. That's a good way to put it. So if you question whether or not it's possible, that might be a reason why you want to look for someone. How about sleep? Like I was with someone earlier today, and she was saying, well, for me, 8 hours out of the question. That she'd be cranky even if she tried to sleep for 8 hours. 7 is a stretch, but she's used to 4.5 hours of sleep a night. Does your sleeping patterns have any tells in regards to whether or not your mental health is well or not?
In certain diagnoses, they
Okay.
do. But sleep is important. Sleep can cause other mental health. Lack of sleep can cause other mental health
Wow.
diagnoses.
Okay.
Like if you're not sleeping and your body doesn't have time to reset, and you're always irritated, or you come to work, you can't get things done because you can't focus, and then you start to have thoughts of inadequacy, and and things
Yeah.
just kind of spiral from there.
Yeah.
And then it's simply just because you're not sleeping well.
Yeah.
Now, sleep is different for everybody, because somebody could tell me they sleep for 10 hours, but if you're not having restful sleep, then it's still not enough.
Gotcha.
You're not doing it correctly,
Yeah.
So their sleep is hard. They also have sleep doctors for that
Wow.
study
Okay.
sleep.
Yeah.
And it's because it is it can be so complex.
Yeah. Yeah.
But it is something to pay attention to. Your sleep patterns change. Why are they changing? Are they changing because you are having trouble falling asleep because you're thinking? Are you anxious? Are they changing because you're waking up often because you're having nightmares or dreams about something that happened? So just so many things.
Yeah. The so young sister, nurse practitioner, psychiatric nurse practitioner. Do you enjoy what you do? Like, and would you recommend for other young people who are looking for a career path in the healthcare space to come into the
Mental health.
Yeah.
So I love mental health, which I always have. I started my journey out of high school actually to be a psychiatrist. I kind of steered away and came back.
Okay.
So it's always been a passion of mine.
Yeah.
I suggest anybody who has the passion to go in it.
Yeah.
If you don't have the passion, then no.
Okay.
It is not anywhere that I suggest anybody just go for the money or the job, But if you have a passion for mental health, it's needed, especially in our community, especially even for, like, age can be weird, Older clients may not respond well, but younger clients think older clients don't know what older practitioners don't know what they're talking about,
Right.
and vice versa,
Yeah.
So having more younger people in the field is good too.
Yeah. Yeah. You what do you think that what do you think people need to know about psychiatric services or supports? Or do you think that there are any myths that are out there that you would like to address in this moment, that or things that people miss in regards to what an appointment looks like or what care looks like?
Well, the overall stigma is something we're working on as a community, but just knowing that, taking away the word crazy, and knowing that just because you do seek help, it doesn't necessarily mean that you have to walk out with a diagnosis of depression. You can come. Therapy can be proactive, not reactive.
Wow.
So knowing that you can go when you're feeling okay too, to make sure that you have the tools that you need when something goes wrong.
Yeah.
Because usually we're on the other end,
Yeah.
trying to provide you with the tools while you're in a mental health crisis.
Yeah.
It's way harder to do.
Right.
And so that would probably be my biggest thing, is to say that you don't have to always look when something is going wrong.
Yeah.
And also to talk. For people who do suffer from a mental health diagnosis, talk to your kids, talk to your family, let them know that you have this diagnosis, what it looks like. So then if they ever feel this way, they don't say, oh, well, my mom didn't. My mom was able to handle this. The whole time your mom was still taking medicine and she was doing things she didn't tell you. So then they're living up to a false idea of their parent when their mother suffered too. So I always suggest just talking.
Yeah.
And you can also, when you talk in a room, you suffer, you may get that person who is suffering too, and you won't feel as alone.
Yeah, got you. So, you grew up. I suspect, and I don't want to try to guess your age, but you grew up during. I guess a period when, just like me, and I'm a little bit older than you, we watched a lot of horror movies. Okay, so whether or not you're talking about Friday the 13th, Halloween,
I kind of watched them like this.
Yeah, right. And all of those shows, and that's just one aspect of the sense of like these super psychotic people who are roaming the streets, right? Like there's this fear that we have as a society, and actually, even if you watch the news, you hear of a lot of bad things happening. Shootings at school and things like that. One would think that inside of the mental health universe, that you're dealing with all of these like super crazy, hyper violent people who, if they somehow get the key to their cufflinks, that they're going to try to harm 20 people. Do you come across any work or spaces like that? I mean, you're you're a professional lady in the healthcare space. One would think that you almost need to have like a shotgun or something, but is that really kind of the
Not at all.
reality?
Not
Okay.
at all. And that is what most people think, even my mom. So, but no, I mean, granted, there are mental health crises. There are people who are severely ill.
Yeah.
They're usually in a hospital or somewhere in a psych institution.
Gotcha.
And I don't work in that setting, so that's not something that I experience.
Yeah.
There are providers who do.
Yeah.
But for the most part, most people are not that severely ill. And just even understanding the diagnosis, we, as people think, for instance, schizophrenia, they'll think that that's that person. Yeah, it may be that person who's talking to themselves, but it's not always that person that's violent.
Right.
So just understanding those diagnoses.
How do you come up with diagnosis?
So diagnosis is determined by symptoms, past history, and really just evidence-based treatments and the DSM-5.
Okay.
There's so many ways to do it.
It's kind of like if it walks like a duck and quacks like a duck, it's probably a duck.
Maybe. Because, again, there are so many different elements to it. For instance, adjustment disorder, which is somebody who experienced something like going to prison, and then now they have these mood symptoms for a consistent amount of time.
Yeah.
It can be adjustment disorder with anxiety, adjustment disorder with depression, adjustment disorder with anxiety and depression. So there's just so many different diagnoses. So that duck may not just be a duck.
Got you. Okay.
But it's also a changing diagnosis.
Okay.
So, as a mental health provider, I always tell my patients, like, okay, this is what I'm thinking now, but it may not be what it is in a few months, because now I have to learn about your history, what's been going on. Bipolar is a hard one to grasp, because somebody who has been suffering for a long time may not report that manic state that they had at 18. But then when you start talking to them and getting into their background and what happened and why they don't talk to their family anymore or something like that, and then you just start digging and you're like, oh, okay, this may be something else.
Yeah.
And you might have to change it.
Yeah. For many of the clients that you see, and like your knowledge of the space, is it like big things that happen in a person's life, like say the loss of a family member or some type of traumatic event that triggers like the diagnosis, or is it something that kind of accumulates over time? And
usually for us in the Black and Brown community, it's an event because we are not constantly taking care of our mental health.
Gotcha.
So that event is what sent you to sent you either deeper into depression and sent you to the doctor, or what sent you to the doctor is just that event. And then you start to say, because a lot of times I get patients and they say, well, I've always been an anxious person. I was an anxious child, and it's like, okay, so you've been suffering for your whole life. Yeah. And now we're talking about why your anxiety is stopping you from leaving your home now, but you've been dealing with it forever.
For when you think of those of us who come from descendants who experienced that were there and experienced the history of slavery, do you see like any common trends or diagnosis with that population, like those of us whose ancestors were slaves?
I don't think so. I
Okay.
would say that there's like a significant trend. It comes from community and your environment,
Okay.
so and how you were raised and the things you were exposed to.
Yeah.
Like mental health is a good percentage of that.
Okay.
So if you were raised in a household who lived in survival mode, they were always in survival mode, then that may negatively affect the children
Got you.
when they grow up and to be adults.
Yeah, it makes sense. Like, we've talked about here in the past, this experience that, those of our grandparents and great grandparents who experienced Jim Crow. So if you were if you were with your child and you had that 6-year-old who just has a natural curiosity, and they saw a white water fountain and a black water fountain, or colored and then a white water fountain, and they were running to the water fountain, and you couldn't grab them, the way that you would parent them and communicate with them in that moment would be one of crisis. So you would basically yell to your child, "Stop!" Right? And so if that child grows up to be a parent themselves,
They don't do the same thing.
and they don't really process the reason why their mom or their dad parented that way, and they just repeated the pattern, they would be the same way. And so
I agree with that 100%. Not necessarily diagnosis, but just how discipline and things go.
Yeah.
Because in that time, you had to discipline your child to be quote unquote tough, right?
Yeah.
Because they couldn't go out there and be, not weak might not be the right word, but they couldn't go out there and just crack and break
or feel free to
right,
do whatever
to do whatever
they
they
want.
wanted. I need to be able to tell you to stop, and you stop.
Yes.
And that's how it was back then.
Yeah.
But we have those same practices because they were passed down.
Okay.
I do agree with that.
So from a nurse practitioner position, I'm going to ask you a question. It's a sensitive question in our community.
Okay.
And that is, are you for or are you against spanking children?
I am on the fence.
Okay.
I mean, like,
All right.
I think that there's a way to do things.
Yeah.
I think every child is different.
Yeah.
I personally don't hit.
Okay.
It's not my practice, but I don't necessarily think that, this new trend of gentle parenting works for every child.
Got you.
Because it does not.
Yeah.
So, it's a way to do it. I think when you have a young child and it's like, you touch that, it's hot, and I pop your hand, because the child doesn't really understand anyway, but they can relate pain to something. Like, no, it doesn't have to be a beating.
Yeah.
You could just say, no, give me your hand back.
Yeah.
So it's I don't know.
Yeah. So when you become a parent, are you going to spank?
My hope
or
is to no.
Okay.
To
All
not.
right. Yeah.
Not. But I understand the other side, just like we were talking about with, I need you to stop when I say stop. We're in this time where we're open to kids asking questions and things like that. But if you're about to run in the street, I don't need you to ask me why.
Yeah, I got
So
that.
trying to figure out that.
Yeah, I get that. It's personal for me. I came from a household that they spanked, but I made the decision for myself that I wasn't going to spank.
Yeah.
And from what I found is there was a reasonableness in my sons, where I never really felt like that when I did speak to them or talk to them, that they couldn't hear what it was that I was saying. And were there moments where I had to be a little snappy and get their attention? I did, and normally that was enough.
Yeah.
I didn't normally, if I got their attention about something, after that they got where I was coming from. So it wasn't like I needed to add to it. But for me growing up, I was my parents would sit me down, particularly my father, and then he'd get me because he'd be like, go and get my belt. So I'd have to, it was a walk of shame, because I knew it was coming. I'd go upstairs. how much does the effects of the style of parenting lead to mental health challenges with children?
100%.
Wow, 100%.
100%. Because the way you parent your child has everything to do with them. So I mean, good and bad. Even when you give the best, it doesn't mean that it's right.
Yeah.
But it may not be 100% doesn't mean that now they have a mental health diagnosis with their own medication and having problems. Having problems with progressing in life, but it can mean like how they interact with, or even for instance, a household where you're not able to question and ask, right? Yeah. And so that person grows up into an adult who may not question or may end up being more of a people pleaser. I try to, in my sessions, I don't like using that word, but being a people pleaser where you just do because in your household you had to. Yeah. That's how I made my mom happy, even if they didn't hit you.
Right.
So those things that 100% they go with you.
Yeah, that's deep right there. So they talk often about needing medication because a person might have imbalances, chemical imbalances in the brain. Is that accurate, or is that a myth, or like this whole chemical balance thing?
It's accurate to a point, and also psychiatry and mental health is still being researched, and the brain is very complex. So we don't know everything about the brain. So chemical imbalance, for instance, like serotonin, yes, okay, we want to boost your serotonin, right? And so if it's here and there, but a lot of mental health diagnosis comes from environment and what you were exposed to and what happened.
Got you.
Trauma can change the brain, and it's really an effect of your body trying to protect itself. So, like a child who grew up abused and raped, disassociating.
Wow.
And then they get to be an adult who disassociates. Wow. But that was the way that their brain protected them as a child.
Interesting.
To endure this abuse.
Wow.
For instance,
wow. That's really deep. Because, and again, it seems like a lot of people perceive the mental health disorders to be less tied to these traumatic events and more tied to this this sense of like their body sabotaging them and just producing more of whatever the chemical is, the biochemical inside of the body that creates depression. It seems as if it's something like their body's self-sabotaging them more so than what I'm hearing you say, which is these events cause them to for the brain to protect itself in a way. It's a little bit kind of like a person gets stuck in fight or flight, or freeze. So let's go with those terms. So fight, flight, freeze. Like, how does that tie into the things that you do, and how do you help clients? How do you tackle the problem of fight, flight, or freeze with clients?
So a lot of times, fight, flight, freeze is usually related to anxiety. So I always try to just help them understand that it's their body's way of reacting to something. For instance, if a lion is coming at you and you're having this response of fight, flight, then it's that's what you're supposed to do. Right. But then this bunny is coming at you and you're having that same reaction, and that's why you feel that way. Yeah. So we have to now retrain the brain to know that you're not in danger. Yeah. And that's like exposure therapy and things like that. Yeah. But just helping them understand what that feeling is. Like your body, again, is trying to protect you because it's having not a realistic response to this bunny, but it's very real to your body.
Gotcha.
And it's getting ready. It's ready. Right. It's ready to fight, flight. What are we going to do here? What are we going to do next? But in reality, your brain, you need to retrain your brain and tell your brain, no, we're okay in the situation. This is okay. Yeah. And that's what, like, exposing a little bit like that can help with retrain the brain. Yeah. It doesn't always take it all the way, but
okay. Retraining the brain. Let me ask you, lay out a scenario. I'm actually going to do I'm going to do a little piece of acting.
Okay.
And then I want to see what your opinion is of this.
Okay.
All right. Action. I don't like what you did. Who the heck you think you talking to like that? That response. We see that a lot of times, especially you look at social media right now. People are triggered. They're snapping off. When you see that from a nurse practitioner, what do you sense is happening?
So because I don't always just see it, a patient will be talking to me about it, right? So I always just ask, like, who is talking right now? Like, why did that trigger you? Is that the little you when your mom used to yell at you, or your dad used to say these things to you? That's talking right now, or is it you right now? Did that person really do something to you right now? And usually, it's the person who dealt with X, Y, and Z that's really talking, and that's where that anger is coming from.
Wow. So some of these responses that people deal with in life, and it kind of is making better sense now. I'm getting clarity. So you mentioned how oftentimes we go through those, these traumatic events as a young person. We witness, you said environment and community. So what we experience. And then you mentioned that when you see someone who gets triggered, that you're asking them whether or not that was something that really was it something that's based off of the actual event that happened, or was it from the past? And a lot of consumers, they have the capacity to like really answer honestly that.
Well, not always. Okay. In that moment, if they say, usually they're like, wow, I don't know, because they don't really have the answer. Yeah. But then we have to think about it. Like, can you tell me a time when, or I always say, maybe tell me a time when you were younger when you felt this way. Was there anybody who said these things to you growing up? Yeah. Or tell me about your household. Tell me about a time when you felt like you couldn't express yourself, or you felt like somebody wasn't listening, or the first time you felt like you couldn't express yourself. Yeah. And usually that gets you back to at least a time frame when you say the first time.
Yeah, got you.
But it takes time. Yeah. They may walk out and say, I don't know, and that's the end. Yeah. I don't know, right, and I can't get them to talk anymore, then we move on. Okay. And we might come back to it next time. We will come back to it, but I like the next session.
So with oftentimes when people think of having to go to a therapist or have their mental health checked or something like that, that's got to be like a hit to their self-esteem. Yeah. Yeah. Is that, what do you think about that? Like if a client comes in, I mean, obviously something is not, they're coming in because there's actually something going on with them, how is it, how much do you have to pour into them to get them to realize that it's not like you're not broken type of thing?
A lot. Sometimes a lot, depending on how they were raised, and what they were told as a young man. What they were told a man is, and what you should deal with or not. So sometimes it takes a lot. But in the beginning, I'm just like, just talk to me. Gotcha. We don't have to in this moment right now. I don't have to send you out here with a prescription. Let's just talk and see what it is that is really going on. And then why do you feel that this makes you weak, or where are you getting that mindset from? And one thing that I always like to do also is say, okay, so if say for instance, like you said, you have sons, so if your son told you this, would you tell him he was weak? So that's what I try to do. I try to what would you say if somebody came to you and told you, I'm feeling this, I'm feeling that? What would you say? Yeah. And sometimes that's enough to be like, okay. Yeah. Or sometimes it just takes more. That relationship, building that relationship and trust is really the biggest part of treatment on my end. Yeah. When a patient trusts you and believes that you understand them or want to understand them and care about them as a person, then they're more inclined to do what you ask them to do. Gotcha. They're more inclined to try this medication, to take it or understand that why, even if they still refuse, but know that I'm not just trying to give you a prescription and send you out the door. I really want to help you, and we can find other ways.
Yeah, that's right. And knowing that you're a young lady from Largo supporting Largo, like I know that's that resonates with them.
Yeah.
Yeah,
Oh yeah.
yeah,
All the time.
yeah.
It's always good to be able to say, oh yeah, I went to high school down the street, or
Yeah.
go Commanders.
Yeah, there you go. I get that. All right. So, first and foremost, I think I want to do these more regularly with
Okay.
you on here because I believe that like the voice that you have and your perspective is so needed. Because and for them to be able to see that you look like them, you look like us, and you're part of us, and you care, as if we're that as because we're part of the same community. That's a value. Maybe next time what we'll do is we will do this and maybe even go live.
Okay.
So if people have questions about their, and I know you can't give like medical advice,
Right.
but if they had questions about like, the what if and could this help them, and maybe we can answer some questions live.
Yeah.
What you think?
That's fine.
All right, all right,
Yeah.
all right. So, that being said, I guess we're gonna end today's interview, and based off of everything that you heard, if you feel like you could benefit from receiving services, there are a lot of resources in the community. Metalworks, we're here, and don't be afraid.
Yeah.
To receive services. We're here to help. So, bye everybody. Looking forward to seeing you guys soon.